Welcome, everybody, to Penn's Leonard Davis Institute of Health Economics. I am Rachel Werner, LDI's Executive Director. Thanks, everyone, for joining us today for our virtual seminar. Today, we will be talking about whether we are ready to reopen the economy. The economy in the U.S. has been shut down since mid-March when the COVID-19 pandemic really took full force in this country. And while the shutdown has helped get the spread of the virus under control, it has certainly caused the economy to take a beating. And there's been a lot of talk in the past few weeks about whether or not we're ready to reopen the economy. Given the urgency of this topic, we're really glad to be able to host today's seminar. With that, I will turn it over to Dave Grandy.
I want to welcome everyone to this virtual seminar today. And we are tackling the issue of whether we are ready to reopen parts of the economy. This is a question that governors across the country are grappling with. There are many unknowns and uncertainties that make it a hard question to answer. And there are clear health and economic costs to different approaches that have immense implications for the American public. States are certainly taking divergent paths, and we will undoubtedly learn from that experience. But we're also faced right now with the need to make decisions. We have an outstanding group of speakers today that think deeply about modeling and trying to inform the decisions policymakers need to make today. And of course, no model is perfect, and predicting the future is, of course, very hard. But policymakers don't have the luxury of knowing the future, and so we turn to modeling to make our best predictions. And so let me briefly introduce our outstanding panelists today. First, we have Kent Smetters. Kent is a professor in the Department of Business Economics and Public Policy at the Wharton School and director of the Penn Wharton Budget Model, which is a nonpartisan research-based initiative that provides analysis of the fiscal impact of policy. Dr. Smetters previously served as Deputy Assistant Secretary for Economic Policy at the U.S. Department of the Treasury and an economist at the Congressional Budget Office. Next up, we have Dave Rubin. Dave is the Director of Policy Lab and Population Health Innovation at Children's Hospital of Philadelphia and a Professor of Pediatrics at the Perelman School of Medicine here at Penn. Dr. Rubin's work focuses on high-risk children as well as the quality of insurance coverage and access for children. And he has presented his COVID-19 modeling work to the White House Coronavirus Task Force and all 50 governors and is advising the Commonwealth of Pennsylvania. Next up, we have Christian Lum. Christian is an assistant research professor in the Department of Computer and Information Science at Penn. Dr. Lum studies algorithmic fairness and predictive policing, including uses of machine learning in the criminal justice system and the potential for predictive policing to reinforce racial biases in law enforcement. She was previously the lead statistician at the Human Rights Data Analysis Group. Most recently, Dr. Lum modeled the spread of COVID-19 in jails and spillover effects to the community. And finally, we have John Rico. John is an economic analyst for the Penn Wharton Budget Model, specializing in tax policy and urban economics. John is responsible for developing and maintaining Penn Wharton Budget Model's tax module to project budgetary and distributional impacts of tax reform proposals. And so thank you to all of our panelists for joining. We are going to start out with 3 very brief presentations, and so I will pull up slides in a moment. And then we will move into a discussion. And then again, I would like to invite the audience throughout the hour to post questions in the Q&A box, and I will get to as many of those questions as we can. So let's get started. Let me get the slides up, and we're going to hear first from Kent, then Dave, and then Christian.
So the Penn Wharton Budget Model, we released this simulation May 1st was our first projection. But if you just Google Penn Wharton Budget Model, you'll be able to see the coronavirus simulator. And basically what we do is we consider 3 different policy scenarios: baseline, partial, and full, in terms of reopening the economy. And the model is unique in being really the kind of the first to do a very integrated analysis between the epidemiological variables that you care about, health and death, as well as economic variables like GDP, jobs, and so forth. Policy scenarios, our baseline is whatever the state happens to be doing. In this case, since we just updated this as of May 10th, And then partial is a reopening partial way, and that by our definition is removing the emergency declarations, reopening schools, and lifting stay-at-home orders. And full reopening are things like even opening up restaurants, sporting events, and so forth. Behavioral choices that people make themselves, even on top of the policy scenario, is actually first order here. And so you can go and play with the simulator. You can pick states. You can do movies of seeing how things change over time. In particular, what we're doing here is we get over a dozen data sets, and we keep on adding more and more data to it. Most of this data is actually at the county or zip code level. We are currently reporting at the state level because in some cases we don't feel comfortable with certain counties. We don't feel like there's enough counts there. The confidence intervals are a little bit too wide. But we have everything from like cell phone data of encounters, mobility, employee scheduling software data. We can look at business openings as well as employment, but also hours worked, which is important because you could have some employee, but just not a lot of hours. On insurance employment claims, even including things like web searches, those are significant predictors, and lots of a whole slew of other financial data, even climate data that we're using at the county level. But essentially, we're using a technique known as principal component analysis to really isolate the key drivers of each one of these factors. And then we use what's called a diff and diff analysis to really separate correlation from causation. We don't have time to talk about that in great detail, but the key is that this feeds into our epidemiological model, which is a SEER model, which actually has two eyes in our model because we have to worry about not just those who are susceptible and exposed, but amongst infected, we have a symptomatic and asymptomatic population that we have to keep track of. And then, of course, the R, as you know, is some of those populations that become resistant, and the ones who aren't R, they go in and they pass away. And in particular, here are the main findings as of the most recent update. Right now, we're projecting out 2 months. We can go out further, but the confidence intervals get a little bit longer. We'll be going out further over time. But right now, under policy scenario baseline, and baseline, the definition is a state is doing whatever they happen to be doing. So there's a lot of heterogeneity about what baseline means. PA is different than, say, Wyoming or other states right now. So whatever they happen to be doing on May 10th, they keep on doing it. And the behavioral scenario is whatever people in those states happen to be doing. Again, there will be heterogeneity even at the county level. They keep on doing that in terms of personal social distancing behavior. And what we project is by end of June, there will be about 2.7 million cases, 150,000 deaths if there's no additional policy changes. And we'll also see an additional 6 million job losses. These are on top of the job losses that happened already as of May 10th. These, by the way, these little call-out boxes this is how the numbers change from our last estimate. In particular, because the baseline itself changed as states kind of partially, what we could call it partial reopen or semi-partial reopen. They didn't quite do the full partial that we've defined it as, but they've done a semi-partial reopening, and so the deaths have gone up. Plus, you have this moving window of 2 weeks. But they also job losses have fallen. We were originally projecting 18 million additional job losses. But notice as now if they go to partial opening, which is the second row there, we're projecting that deaths would go up to 183,000. So by partial, we mean in our definition of open up schools, although we recognize that schools are on summer break right now, as well as the stay-at-home orders, as well as the emergency declarations get reversed. And so we'll go 183,000 deaths by end of June. But notice, and I won't go through all the table, but the second to the bottom line of partial reduced distancing, the policy is still partial, but now it has changed as people's behavior. And the idea here is that suppose that people view the partial reopening as a signal that things are okay, that they don't have to necessarily stand 6 feet apart and maybe wear masks. They can gather together in larger groups, things like that. And under this reduced distancing, the assumption is by December, They returned to the pre-pandemic levels of personal social distancing. So the idea is, and it's on a log scale. So most of the actions happen in the first couple of months anyway. But notice that deaths now increased from 183,000 on the second line all the way to 285,000, just simply from that behavioral change. So it actually turns out personal behavior matters tremendously in this. Of course, it also has a big impact on jobs as well, because as social distancing goes down, you're going to have fewer job losses. In fact, we would project that you, in this case, actually gain 2.9 million jobs, which will offset the 30-some million jobs that were lost previously.
All right, thank you, Kent. Let's move on to Dave.
This has been sort of a really interesting few weeks as our models have gotten a lot of interest at CHOP. I just want to recognize my collaborators. When this epidemic began, in my experience over my career doing health services research and epidemiology has been around local area variation for children and families with regards to health services. And I was, at the virtual water cooler at the beginning of this epidemic. I talked to Greg Tajan, and I was very familiar with his work. He's a pediatric urologist in the Department of Surgery, and he does work on the effects of climate change and particularly warming environments on kidney stone formation. And Dr. Jing Wang is in the Department of Biostatistics, and she had experience, and I interviewed her when she, for her faculty position as she came on faculty here in the last couple of years, a tremendous amount of experience in longitudinal data analysis. And together, the three of us began to talk about a project that would focus much more locally on issues related to the outbreaks we were seeing across the country. Some people have asked me, how did modeling the COVID epidemic become such a priority for your group? Well, we knew early on that the families that we care for, and particularly here in Philadelphia, that the caregivers, many of whom are older, because we have a lot of grandparents caring for kids, were going to be facing the actual impacts of COVID directly with regards to their own health. Certainly, we were worried about the kids. We were worried about whether the kids were transmitting, et cetera. But we also knew that as we eventually do recover from COVID, that the indirect impacts tend to be more sustained for working families. And already, this is a slide from the Brookings Institute demonstrating the rates of food insecurity that we've seen also as well in our community resource mapping through communityresourceconnects.org. We've seen a tremendous rise in the number of food insecure families as joblessness has mounted. And so if our modeling could be positioned in a way to help communities safely reopen, we didn't want communities to be closed for any longer than they needed to be, and figure out a way to get people safely back to work and to school. And so that was why we embarked on this project together. So I don't have a lot of time to show you all the models. You can come to policylab.chop.edu. You can see the models. Right now we're up in about 211 counties. Next week we are putting up new models with shorter forecasts as places reopen. It was nice to do scenarios and simulations when everyone was sheltering in place, but things are opening up right now. But we're growing to 400 counties across the country. The greater majority of the population and the cases around the country. But I'll just stop here to show you what we're actually doing. It's a really sophisticated approach that instead of using the SIR models, we're focusing on mixed effects general linearized models that allow us to include time-varying information in the estimation of what's called the instantaneous reproduction number. We assume that the reproduction number, or the number of people infected for every infected individual, varies by where you live. It varies every day by our behavior. And this was a method that was promoted by Corey Malinga in the modeling of the Ebola epidemic. It was reported in JAMA in the modeling of the Wuhan epidemic. It's a very flexible model that allows us to include time-varying information such as social distancing, which is measured using the cell phone data that was reported in the New York Times as a measure of percent change in visits to non-essential businesses like hair salons and restaurants. We include population density. We actually really used a parsimonious model after lots of tests for multiclinearity in our explanatory model, focusing on age distribution within counties, poverty rates within counties as primary predictors. There was lots of collinearity with other factors. Diabetes percentage ended up in the model as well too. And then we introduced climate. We introduced temperature change, working with Antonio Gasparini at the London School of Hygiene and Tropical Medicine, who had been working with Greg Tajan for a long time. And we use distributed lag nonlinear models, which he has elaborated for use in studying the effect of climate on mortality. And that assumes that we knew that we had these lag temperature effects that in our models are now lagging between 4 and 14 days before case estimation or the estimation of our reproduction numbers. Because you're trying to figure out what was the effect of temperature, in our case, wet bulb temperatures, which combine temperature and humidity, at the time that individuals were exposed and inoculated. And so there's a huge spread of lag days that you have to include, and each of the effects of temperature on each of those days is nonlinear, and so you end up accumulating a response related to the effects of temperature that we have found over time have become much more significant. So our models are much more optimistic about the summer, even as they may be even more pessimistic about the late fall. Now, just to orient you on the right here, you have the actual cases over time in Philadelphia up till this week, after which we are using a prediction model which uses the beta estimates from our original model and actually uses an autoregressive model that relies heavily on what yesterday's R was. The left side shows the reproduction numbers, and what we're simulating here are different scenarios that a county might do. And so reg is the most aggressive strategy. On average, we've had about a 73% reduction in social distancing in Philadelphia during sheltering in place. And so we assumed if people were really aggressive and we went back more than halfway back to normal, which is really only a third less of what you were doing before the epidemic, you would expect, and I think the relative inference is important, that there would be a resurgence of infection that would eventually start declining, temperature working against this, but there would be a lot more cases and deaths. Blue sort of assumes that, okay, maybe we go slower and we open and we're doing half of what we were doing before, which is about a quarter of the way back to normal. Well, we can talk about how hard it is to know what that means, but people intuitively can feel it's cautious. That's our cautious strategy, and it shows that you get a little bump, but then you start declining. And then if you wait a couple of weeks, you do the same assumptions, you see you have a much more natural decline because you're starting with fewer cases and low R's. So this led to the ability to really look across the entire state, because when we see someone who from a rural area who's very upset that they can't go back to work because they're not seeing circulating cases, they're not wrong. But when we see someone in New York or Philadelphia who's witnessing the tragedy of what we're going through, who can't believe that anyone would protest a sheltering in place strategy, they're not wrong either, and it's because of these local area effects. And so I'm showing you a map of Pennsylvania, and basically as you look at it, we're now modeling in 24 counties across the state. There's a wall that forms around the southeast that represents what I think is the metro area of Philadelphia. That is the high-risk area in our models, with higher numbers of cases, higher reproduction numbers. It goes out to Berks and Lancaster. But once you start moving beyond York and Dauphin and going west, they've had fewer circulating cases. And our forecasts for them have been much more optimistic. As you go up into the Poconos, Luzerne, all those Philadelphians going up to their lake homes up there on Lake Naomi have caused some trouble, but there's also a prison up there where there was an outbreak in Columbia County. But most of the Northeast is now starting to soften up, even those areas around Pike County. And then the rest of the state, particularly the T, there's been no activity. So that has led to Governor Wolf's identification that we can start to selectively open many counties across the state. They're going very conservatively, but it's getting people back to work, but they're going cautiously and slowly. And you're seeing that other governors kind of do the same thing. You're seeing Governor Cuomo do that in New York. He's opening up upstate, even as he waits a little bit longer in New York City. And so that's been the basis of our modeling, and our forecasts are going about 3 or 4 weeks, because now we're going to watch places open. We're going to add some additional distancing variables to our model, and our goal is going to be, did you overshoot? Like, are your cases getting worse in the next 3 or 4 weeks? Are they getting better, or are they getting worse? And so to help places understand that they still need to remain cautious. Temperature alone is not going to mitigate transmission. It's going to need to be combined with smart behavior around masking, hygiene, and disinfection.
All right, let's move on to Christiane.
I'm going to be talking to you today about a model I built with my colleagues Eric Lofgren, Nina Feckerman, and 2 researchers from the ACLU, Aaron Horowitz and Brooke Maduwangu. And in this model, the idea was that we wanted to model the spread of COVID within and between jails and the broader community. And so to do that, what we did was we built a somewhat enhanced SEIR model. And so just to give a quick overview of what that looks like, I know we already saw one in the first presentation. In this model, the population transitions between disease states. So S are people who are susceptible, they have no disease. E are people who've been exposed. I are people who are now infectious and they can go back and infect the population that's in the S category. You'll see a little M on this figure here. So people from I can transition into M, which the M stands for medical in this case, people who require medical attention, or they can transition directly into R. So R stands for, in this case, removed. So if you go directly from I to R, you're recovering. If you go from M to R, there's some chance that you're being removed from the population via death and some chance that you're recovering. And in this model, all of those rates of transmission and rates of progression through those different states were calculated from external studies based on data on the sort of clinical progression of the disease. You'll also notice that we have different categories of people in this model. So children, low risk, high risk, elderly, adults, and separately jail staff. So simultaneously, while the population is transitioning between these different states in the disease model, people are also transitioning through this model of location changes. So people are transitioning from the community via the process of arrest. Some people in the broader community are arrested, and from there they are brought to something called processing in court. So this is essentially intake, booking, something like that. And from there, some of them end up going to jail. So within jail, people go back and forth between jail and processing in court via court dates. They have appointments to settle aspects of their case. They'll have to go back and forth to this processing in court. And people who end up incarcerated, also many of them do end up back in the community. So the jail, one thing to note here is that the jail is not really meant to be a long-term housing facility. In many cases it is. It does house people who are serving relatively shorter sentences, but for many people who are there, they're people who haven't been convicted of anything, and in some cases they'll make bail or there'll be other solutions worked out so they can be released. So one thing to keep in mind is that the jail is a porous place and people do go back and forth. So people end up in the jail and they transition back to the community. Over on the right-hand side, you'll see this staff compartment. So jail staff also do not live on site. They go back and forth to the broader community. And so the parameters that govern this sort of movement between the locations were designed after information from Allegheny County, Pennsylvania. The reason for this was largely data availability. That county has a fantastic website where you can find things like arrest rates. You can find things like, sort of broadly speaking, how many times people are being transported back and forth between jail and processing. You can find things like how long on average people stay in jail before they return home, and also they had information about the number of jail staff. So we are able to parameterize our model using information that was realistic. So we get realistic rates of movement between the different compartments. And so what we found when we ran our model was largely unsurprising on the left here. So we found that within the jail, we end up with these raging outbreaks fairly early on. And in the community, if we do practice something like shelter in place, we are able to sort of smooth out or flatten that curve. But one of the interesting things that we found is that the jail has spillover effects into the broader community. And so if you can reduce infections in the jail, that will lead to reduced infections and deaths for everybody. And so the way that we saw this was we tried out several different policy interventions, things like reducing the number of arrests, so reducing the number of people that end up in the jail where there's this raging infection because people are in close quarters. In many cases, in jails, adequate hygiene supplies aren't given, so people have to buy their own soap with very, very limited resources. And so when we looked at, in the figure on the right, you'll see these different bars which show the number of infections in the community, hospitalizations, and deaths for community incarcerated people and staff. And the top bar shows what happens if we just shelter in place in the community, but we do nothing about the jail. We let that epidemic keep just going full bore there. And we see that bar is the highest. So we see the largest burden there. We see the most infections, we see the most hospitalizations, and we see the most deaths, both within the jail, so both among incarcerated people, but also back in the community. Because remembering that people, because this jail is a very porous place, right? So people are going back and forth. Staff members are going back and forth. Incarcerated people are being released and reseeding infections in the community. we find that if we try out these policies where the number of arrests is reduced, either by not bringing bail-eligible people into the jail at all, or reducing the arrest rate for vulnerable populations only, or releasing all low-level people who are currently incarcerated for low-level offenses. We see that those benefits spread out. The benefits don't only accrue to the incarcerated population via lower numbers of infections. There's also lower numbers of infections that get passed on to the community. And so we're actually already seeing these sort of dynamics that we see here play out in the real world. An article by the New York Times looked at some of the top clusters in the United States, and they found that 29 of the top 50 clusters were in jails or prisons. The New York Legal Aid Society, which is a fantastic organization of public defenders in New York, looked at the rate of infection at Rikers Island, which is the jail in New York City, and they found that the rate of infection with COVID there was higher than epicenters in Italy and Wuhan. Another interesting data point is that there's been an outbreak in Marion County Jail in Ohio, I believe, and that has been linked to community outbreaks as well. And so I'd like to close by saying that I know for a lot of people, the incarcerated population is not necessarily a sympathetic population. I understand that for some people, it's hard to get really excited about thinking about the issues there. But I think we need to think about, the sort of magnitude of the problem. Every year, there are about 10.6 million jail admissions a year. That is a lot of people. There are about 240,000 jail and prison staff nationally. All of these people are at very increased risk for infection and death by COVID simply because of the conditions. I will close there.
But there's a number of themes that I think came up in the three presentations. And one of them has to do with the idea of mobility of populations, and obviously with contagion, mobility is a pretty big deal. So Christian, you talked about the kind of spillover effects from a jail. Dave, you were looking at some of the kind of different, like within region differences here in Pennsylvania. And I want to come back to this point. And so, Christian, maybe I'll start with you, and then Dave. Are we paying enough attention to this issue of like the movement of populations? And how might we think about that with respect to not just incarcerated populations, but other vulnerable populations?
I don't think I can say in complete generality that we are or are not paying enough attention to mobility. Certainly there are people, and I think we've seen some examples today, who are using highly detailed mobility data, for example, to inform the parameters of their disease spread models. And so I guess I would sort of pivot a little bit and just say I think what's really important here is to keep track or explicitly include in your models particularly vulnerable populations like incarcerated people, populations like unhoused people, who might not necessarily be included in a sort of typical modeling environment, like with the understanding that every model is a simplification. Every model does have to make some sort of simplifying to get any leverage to actually do that modeling, right? But if we really want to understand the heterogeneous effects, not only over space, I guess unless space could be constrained to say like one small facility, I think we also need to be, paying attention to this, how the dynamics play out differently.
And Dave, I know you emphasized a great deal some issues around population density and more kind of urban areas and the proximity of individuals to others. And just picking up on this idea of, how people socially, kind of what their social exposures are, but then how people move around a lot. You brought up the instance of people going up to the Poconos, people in the summertime maybe moving around a lot. Is it possible to draw lines across counties, in terms of human behavior? Like, how might we think about creating policy? Can it be different in Philadelphia versus a suburban county, suburban counties versus rural counties? Where are safe places to draw lines and not draw lines?
We have a saying, within the group, the R's are the R's, like they reveal what's happening. I mean, we're going to be adding commuting and even airport travel into we're trying to acquire FAA data in terms of to try to pick up on some of those mobility differences. But our random effects at the county level and our actual R's are detecting what's actually happening. A couple outtakes, with Luzerne, people drive up the Northeast Extension, the counties just below them, like Schuylkill County, like those areas were pretty empty. people are not making stops up there. And it was very clear that it was hopping over these counties to get to Luzerne. So your points about mobility are well taken. And I think as people have asked me about this, it leads me to think that we're not opening county to county. We're opening regions. And they largely play along these mobility zones, so like it doesn't make sense to open Montgomery County without thinking about Philadelphia. What does it mean to open up restaurants in Montgomery County if people from Philadelphia are just going to come out to Montgomery County and go to a restaurant there? But it largely does play along the ways in which people commute. Lehigh has not seen the pressure that Philadelphia has because not many people are commuting to the Lehigh Valley from Philadelphia. And so you see these differences. The other thing that we haven't been able to incorporate, which is as we reopen and as we move around, how much the masks that people wear and their individual distancing, in many ways discount the amount of social contact that we're beginning to have through our mobility. And so we've been messaging the value of masking, the value of hygiene as a way to maintain effective social distancing as we move. And we're hoping to see data that can tell us, like, what is that adjustment factor if people are wearing masks, because it still remains controversial.
Kent and John, I want to bring you into the conversation now. I think one of the really interesting parts of your work is to try to understand this connection between the policies that states are creating or have in place and might relax, and how people may respond to that in terms of their own behaviors. So picking up on what Dave just said, like, are people really going to return to restaurants again, even if you lift these policies? So I guess the question is, you presented some data to try to look at that connection. How much do we know about that connection right now? And is it kind of rapidly shifting to some extent?
It is. And in particular, even at the zip code level, which we can dial down into, what we find is that personal behavior is incredibly important. That's what those numbers were actually showing. What we're not doing right now is taking a stand in terms of when a policy is being changed, what will that change in personal behavior be? Because simply we don't have that evidence yet for the United States. We've seen it in other countries, very mixed evidence. We saw in Hong Kong, for example, there was a big change of personal behavior. People apparently took the policy change as a signal about the risk factors, and they substantially lowered their own social distancing and saw some resurgence of a kind of a second wave. As we get that information, we will start to incorporate that. For now, what we're saying is we're presenting them side by side, saying if this does happen, that becomes important. Remember that in this case, we found that as we go to partial relaxation, and that means every single county is doing it in PA and other states, and it's doing it with our definition. We found that deaths are going up by 33,000. But if in fact you actually have a change in this personal behavior, an additional 100,000 in deaths nationwide. So that personal behavior is absolutely critical.
How quickly are we getting updates on those behaviors in terms of modeling so that we can better understand how populations are responding? And again, there may be heterogeneity across states for sure, but how people respond to the lifting of restriction.
We're seeing that in real time. I mean, we have daily data. That's what our model's based on. We construct these daily frequency activity indices, and they come with a couple of days lag usually. But you can see that sort of thing right now. If we look state by state, in the places that have recently sort of eased some of their lockdown measures, and even in places that haven't, social distancing is declining pretty much across the board. What we're also seeing as really preliminary evidence, even in places that have like eased access to restaurants and so on, it's just a very small increase. People are not flocking back in great numbers. And so, obviously the evidence, we're going to have to wait a couple of weeks to really see how this plays out. But, as Kent said, right now we're not taking a stand. We're just going to present those things side by side.
One thing I'll point out is that our analysis showed that R was coming down even before a lot of states locked down. personal behavior was changing even before and that also impacted economic activity. So it's actually not true that it's all policy that's reducing economic activity and generating the social distancing. Restaurant activity and lots of other activities were actually coming down even before states implemented those policies.
I think it'll be interesting to see how that connection changes over time. As people are asked to engage in these behaviors for longer periods of time, the relationship between policy and behaviors may be rapidly changing target.
That's right. The fatigue.
Yeah, the fatigue. So, Dave, I just want to come back to this weather question for a moment because it does seem to play a big role in your projections. How confident are we in this relationship between climate and contagion here? Are we still learning what that relationship looks like?
We're getting more and more confident about the temperature effects that we're seeing. There's some question about whether is it temperature, is it humidity, is it UV, which some people believe it's exposure. They tend to co-migrate together, so it's hard to model them simultaneously. But I'm fairly convinced there's an element of climate here. Our models demonstrate, though, that the impact of climate is nonlinear. To some degree, when you're looking at temperature effects, there's a nice linear effect where your reproduction rates come down as temperatures warm in the temperate range. At around 65 to 70 degrees, what do people do? They go outside. They go to gatherings, and so you tend to pick up some gathering effects that may over a small range of temperatures, around 65, 75 degrees, actually increase your R's a little bit. Not to the degree they are at lower temperatures, and then you reach equilibrium again. You start falling again, and we're seeing that more dramatically over time as we add additional counties. We're seeing it. We're still waiting for temperatures at the very high range, 95 and really humid. We've got pretty good evidence, not necessarily from SARS-CoV-2, but from other respiratory viruses, that respiratory transmission decreases as you get to particularly hot and humid weather. Those droplets don't hang in the air as long. They drop to the ground. There may be more fomite transmission, which isn't as explosive, which can explain why areas like Houston and Miami are smoldering. They're not extinguishing, so you can't mitigate it at higher temperatures, but they may be switching more to fomite transmission, which illustrates the need for hygiene and disinfection as we move into summertime. But I would say that, our feeling is it's just difficult to model, and people have been uncertain about how to distribute these lags, but our team is fairly confident that we're picking up a strong signal that temperature's involved, but not enough to mitigate transmission entirely.
I want to turn to some of the questions that have been sent in. There's one individual who lives in Georgia that has been very aggressive in reopening. And the heart of the question really is that they haven't seen a big spike in cases. And how long will it take to, really get a sense of, how a change in policy results in incidence of disease?
We're not seeing the explosive growth in the South that we're seeing in these Northeast or upper Midwest cities. Chicago's still struggling. Minnesota has struggled. And to a large degree, we believe temperature is mitigating transmission. The areas of the South tend to be less dense compared to the industrial cities of the Northeast and the upper Midwest. And then people are being cautious. It's, I don't think it's been a mixed bag. I mean, the importance of individual distancing measures is particularly important in crowded indoor locations. When people go out to the beach, I think there's, some gathering evidence that that's not a risky maneuver in and of itself because of the UV, because of the natural ventilation that you have. And so I'm not surprised by what's going on in the South, and our models sort of seem to suggest the same thing.
I mean, the one thing I would say, the reason why we're maybe not as bullish yet on temperatures, only because you really have to, exactly what David said, is distinguish between the density. Colder climates right now also have cities that tend to be more dense, and so the contagion factor tends to be higher there, and really teasing out how much of that is coming from density, how much of that's coming from climate, and then besides this these principal component analysis that we're doing, really trying to then use this depth and depth to try to tease that out. It separate correlation with causation. That's where the challenge is. But I think, David's exactly right. As we get more and more data, we'll get more and more confident about those distinctions.
Hey, Dave, can I just add one thing? The danger in our models is that if we see scenarios in our models, some that we've shared publicly, some that we haven't, when we incorporate seroprevalence into our data, we're even, particularly in some of these hard-hit areas of the Northeast, I wouldn't be shocked if we had predictably normal-looking summers, right, in many areas with very few circulating cases. And the danger there is complacency. That people will think, okay, let me take off that mask, I don't need to wash my hands, and they'll get away with it, largely in the summertime. And then we hit the fall, and just as optimistic as we are in the summer, those elevated Rs we're seeing in colder temperatures as we switch back to respiratory transmission would suggest that our peaks in the fall, if people are not careful, could potentially be higher than others are forecasting.
Obviously whenever you approach modeling the impact of something across a large population, it can obscure some of the differential impact on different populations. So Christian talked about specifically the concerns among incarcerated populations, but there are other populations, of course, who could be differentially impacted. Are there ways that, maybe Christian, asking you if you want to jump in here, ways that we should be looking at, subgroups in models, and seeing how these effects are distributed across the population?
Thinking about bias in the data, right? So the data is going to sort of differentially record data about different subpopulations, and particularly marginalized populations may not always end up appearing in the data. And so when we think about what I mean when we're talking about a biased data set, I think that term tends to get overloaded, so I should back up a second. So often as a sort of a technical person or a statistician, I think of statistical bias, like the data sets are less likely to record some people than others. So we'll see that in things like polling data, especially with landlines. Older folks will be more likely to be recorded because they answer the phone, and also they have landlines. But there's also issues around historical bias, so which is when the data accurately reflects reality, but the reality is itself a problem. And so I think one of the biases we're going to see in the data when we start trying to tease out the effects in the different populations will be around sampling bias. So in the beginning of the epidemic, when testing was a lot less common, I remember seeing, who is getting tested. If you were an NBA player or you attended a Republican convention or you were Tom Hanks, you had no problem, right? But people who were even healthcare workers whose children had symptoms and things like that were having a whole lot of problem getting the tests. And those are the sorts of cases that don't end up appearing in your data. So even if there is some population that ends up appearing perhaps less affected by the epidemic, I think especially when we're relying on things like cases, positive tests, things like that, we have to think about how the tests are being distributed and who's sort of being ignored in all of this, who's not showing up for healthcare, and who's sort of excluded from the data, whether intentionally and probably generally not intentionally, or via the sort of patterns in society that lead to people not showing up in the data sets we might use to evaluate whether a certain location or community is ready for reopening and what the effects are in those locations.
There's a couple questions here that have to do with how we measure behavior. And so it sounds like there's a great emphasis on using cell phone data around tracking movement of individuals. But then there may be other more granular behaviors that are important for the spread of COVID. And so one of the questions brings up like the role of masks, for example. And are there ways that in your models you're starting to think about other behaviors that you could measure in a more granular way other than movement?
One of the things that we project out is how, for example, changes in testing will evolve over states as well. So we need to project that out because that will have a big impact as well. So we also have to project as part of personal behavior, things like use of masks, things like that. I mean, I think what Christian just said is incredibly important. I don't want it to get lost, and that is, right now, there's big issues with sample selection bias in the data that is available. And this actually comes back to the Georgia question in terms of there's maybe a big difference between cases and infections because of sample selection. But even case fatality rates, you would think by now we would have a good idea of that number. We actually don't in the United States because of a huge sample selection. Even the study done in California, which tried to use a more randomized approach to figuring out what infection rates were versus cases. The problem there, we know in a lot of these surveys, is non-responders are differentially selected, and that is they are not the same thing as responders. And we don't have a forced swab census going on in the United States. This is what you really need to get good data. So it's just going to be a matter of time. And even then, there will be great debates, in the next, several years in retrospect, whether we were using kind of the right data. But getting the good quality data in a society that values civil liberties and things like that is very challenging.
I'll say a couple things to your question, Dave, because our research team has talked about that. I mean, they're very challenging. I mean, the masking is the one that we're most interested in because that's the individual intervention people can do to maintain some effective distancing in indoor locations. We briefly thought about failed Apple Pay transactions, the facial recognition software, because people, if you've noticed when you've gone to the grocery store, your Apple Pay doesn't work, right? And you have to put your passcode in, and could you recover that? Unfortunately, we're learning that the hipsters have figured out how to rejigger their phones, and it may not be the most representative sample because not everyone has a facial recognition edition of the Apple iPhone. There are machine learning methods that you can use using CCTVs in some of these counties. They require a substantial server, is our understanding, but the people who do machine learning methods can use CCTV footage to look at whether people are wearing masks. And then the final thing we thought about is to assume that when you're modeling social distancing, the cell phone movement, that the relationship is not the same over time. That on the way down, when we weren't wearing masks, you get a certain relationship, which is very strong. But as we open up, it's going to be modified by masking behavior. And don't assume that the betas, if you will, for social distancing are the same now as they were back in March. And so there are ways that you can try to indirectly get to it. I just want to finish for Christiane. I mean, we've seen the effects that you've talked about up in Luzerne. I mean, it's similar with nursing home outbreaks because the staff travel long distances to work in these locations. I think the issue about these specific crowded, these areas of crowding, whether it's nursing homes, prisons, immigrant communities, mass transit platforms, the meatpacking industry is very interesting because they live in congregate care facilities as well, too. A lot of migrant workers are working in that industry. This is an issue of surveillance and testing. We talk a lot about testing, but the precision use of testing and sentinel surveillance, where you actually, it would make a lot of sense. It's the areas that need enhanced testing are the prisons, they're the nursing homes, they're the immigrant communities. They're not the Walmart down the street in Montgomery County. And so as we try to respond and mitigate, we need to recognize that and act accordingly with the testing capacity that we have.
Yeah, you're bringing up an important point, which is I think a lot of the way people are thinking about reopening is, of course, contingent on having some of that testing capacity in place and some of the public health infrastructure in place. So I think that certainly one of the concerns is if that infrastructure isn't there, then that could certainly complicate matters with reopening. I want to just move to a final question, which is, models often produce different results. This is a space where lots of people are trying to very quickly come up with estimates to advise policymakers. And, how should policymakers think about differing estimates that come from different models and make decisions?
We're humble enough to know that you never trust even our own models have their limitations. And I think the truth is somewhere in between all these models. And you need to kind of listen to what people are saying. And there's usually an inference to take away from each of these models, and you incorporate that into your vision and your strategy. And so I would be cautious to believe any one model alone, but try to incorporate different pieces to get your best sense of what you think and what you hope the truth may be.
Christiane?
When policymakers look at these models, they need to view them, I think, as a range of possibilities. So rather than looking at one particular projection or prediction, look at sort of the range of values that's coming out, and also consider each model for the strengths that it brings. Each model sort of treats different components or different aspects more thoroughly than others, and so for the particular thing you're looking at, try to use some critical thinking and think about which models are relying on the most realistic assumptions that are most pertinent to the question you're trying to ask, and then look at the range of values.
Any one model has a pretty wide confidence intervals, which is always a bad expression because it really should be called an uncertainty interval when you talk with policymakers. They think wide confidence intervals means lots of confidence, and I always have to explain to them, no, it's just the opposite. And so there's a lot of uncertainty in any one model, but typically you place more weight when lots of the models are saying the same thing, and at least as a general trend. And that's where I think that you can get some strong takeaways from these models is that if they are they are trending in kind of the same direction in many cases, or where they're not trending in the same direction. That's where you have to start asking really specific questions: why one particular model is not behaving like the others, and so forth. But I think what's really neat about leaving this, maybe as the last comment here at Penn, is having an interdisciplinary approach is really key about this. And that is, the economists can't solve this alone. The epidemiological and virologist experts can't solve this alone. This is a time where we just need to really come together. We're seeing that in the data provider side. People are really being selfless and sharing data. And this has to also happen on the academic side. Just coming together and really sharing the best insights and working together in an interdisciplinary way.
I want to thank all of our panelists. I think that a lot of this work being done is certainly meant to inform some very, very difficult decisions that I think elected officials are facing today. I think governors around the country are really struggling to figure out the appropriate next steps, and I think this work can be very helpful. At the same time, I guess my own public health message would be, to continue to encourage people to practice some social distancing and good hygiene measures, or even any kind of relaxation, I think will quickly be reverted. And at the same time, hoping that our states and our federal government can really begin to stand up much more robust testing capacity, again, that would facilitate, I think, some of the reopening being successful. So thank you again to everyone.